participants. Welcome to today's session. Today our faculty is Dr. 𝒂𝒔𝒉𝒂𝒂. He is Associate Specialist Teaching Lead with Hull Yorkshire Medical School and Princess of Wales Hospital, Grimsby, UK Cardiology. His area of interest is non-invasive cardiology. Sir, over to you.
Thank you. Now, I'll go through the several topic bundles, but first of all, I want to go through the questions first. Yes, so if you read this question, the next question is not, the question is not what you are going to add next. The question is, the physician added 𝒂𝒂𝒂𝒂𝒂𝒂𝒂. So the fourth medicine they added 𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂. The question is more of a fundamental that 𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂, what is it? So they could have asked this question straight away, but they have given a long story. But the question they are asking, it has nothing to do with the story. So straight away, they want to know that what is the mechanism. And as you know, it's a direct renin inhibitor. So that's an easy question. But what they're trying to tell you that, first of all, RAS is their favorite topic. So as you know, angiotensinogenes all starts with angiotensinogen. Then you have renin, it converts to angiotensin 1, and then ACE, then it comes to angiotensin 2, and then angiotensin 2, it works on the angiotensin receptor. So you can block the renin, and then you can block the ACE, and then you can block the angiotensin receptor. So they want to know that, do you know RAS? So that is the topic. Now, you all also have to know that what is a nice hypertension guideline. It means the question may be that what you are going to add next, the 3 medicine did not work. So from this is the official NICE guideline, and from that you can be asked 20 questions. So understand this and you will be able to answer the questions. So funny thing about this guideline, look carefully. We first differentiated NICE, all hypertensive patients, into 2 categories. Do they have diabetes or they don't have diabetes? So most of our population, they don't have diabetes. So this is the bigger group. So obviously, if the age is less than 55, then there are 3 divisions, whether they're young, whether they are relatively old, or whether they're Afro-Caribbeans. So why these divisions? Because if, say, in white population, there is high level of renin. In Afro-Caribbeans, the renin level is low, and in Indian subcontinents, or you can say brown, the renin is sort of intermediate. So this is for the white population, but if they're young, so relatively the renin is high, so you use an ACE inhibitor or an ARB. Now, if the patient is a bit older, you're using calcium channel blockers, maybe amlodipine, any calcium channel blocker, representative is amlodipine. But if the patient is Afro-Caribbean, then you are not using an ACE inhibitor, you are using calcium channel blocker. But that doesn't work if the patient is diabetic. If the patient is diabetic, then the things changes. So diabetics straight away, whatever be their color, they are taking either ACE or ARB. And that is a very important thing to realize. Now in step 2, whatever you did not add in step 1, you add in step 2. So if you have added ACE here, you add a calcium channel blocker. You have added calcium channel blocker at the first step, you add ACE in the second step, okay? Now, third step is usually a diuretic. Now, the question may be, a patient is on hydrochlorothiazide, amlodipine, ACE inhibitor, or ARB, what you're going to add next. Now that is very important. Here you have three choices. Either you add spironolactone, depending on the potassium. If the potassium is on the higher side, you don't want to add spironolactone. You add either an alpha blocker or a beta blocker. So the second topic bundle is, do we understand NICE hypertension guideline? Now, moving on, the next question is, a 76-year-old male came to cardiology with a complaint of breathlessness during physical activities. As the symptoms are self-limiting, he didn't give much importance. Fine, then he wants to assess his heart function. That is why he came to clinic. Now, echocardiography revealed aortic stenosis with insufficient pressure gradient. Okay, carefully. Aortic stenosis with insufficient pressure gradient. It's like a mild aortic stenosis or moderate. Among the following options, we describe the best pathophysiology of aortic stenosis. So the question they're asking, there's a long question. The scenario and the question, they are not very much related. So sometimes if you just quickly read the question and go to read the scenario and go to the question first, you'll be able to answer quickly. So what they're asking now, so what is the pathophysiology of aortic stenosis? That has nothing to do with how the patient presented. So it's sort of a wasting time if you like to read in between the lines. So basically, it causes concentric left ventricular hypertrophy because it's a pressure overload, aortic stenosis. It may not be severe, but it may be moderate, but the main mechanism of aortic stenosis is increased afterload, leading to concentric left ventricular hypertrophy. So it's a very theoretical question with a clinical background without much connection. Now, question 3 is 72-year-old man. Oh, at this point, I'd like to show you some PowerPoint, okay? So the topic is, do I understand the difference between concentric hypertrophy, normal heart, and asymmetric septal hypertrophy? So that is the question. So hypertrophic cardiomyopathy usually causes asymmetric septal hypertrophy, where the proximal septum is much thickened compared to the area towards the apex. But this is not the only pattern. So hypertrophic cardiomyopathy can present at different forms. Even a concentric LVH may be hypertrophic cardiomyopathy. So this is a tricky part, maybe in part 2, but also in part 1. So commonest pattern, asymmetric septal hypertrophy, but one can have concentric LVH or one can have apical cardiomyopathy. Now, apical cardiomyopathy is a favorite topic of MRCP examination, more than hypertrophic cardiomyopathy sometimes, I feel. Now, yeah, these are the 4 different types of hypertrophic cardiomyopathy. Sometimes there's a question on myofilament gene. Maximum myofilament gene is seen in asymmetric septal hypertrophy type. Now, apical hypertrophic cardiomyopathy, the question comes in different forms. Sometimes there's an ECG, and the history will be that this patient does not have hypertension, does not have aortic stenosis, but this is the ECG. Maybe the question may be a young man, 22-year-old, wants to join army, came for a routine medical checkup before joining army, and that's the ECG. So as you can see that there's a deep T-wave inversion, mostly septally, and also bilaterally, very deep. So, and if there may be this ECG, but they are very different. So both are hypertrophic cardiomyopathy, but here you see it's septally. The important topic, Adenosine, no, you don't want to give fast adenosine. This is for SVT. Digoxin, no, it doesn't cardiovert. It makes things persistent. So if you give digoxin and then chance of going back to normal rhythm is less. Beta blocker, no, beta blocker does not, unless it's a designed beta blocker, it usually bisoprolol. If you give somebody bisoprolol and after 3 hours, the patient goes back to sinus rhythm, this has happened by chance. Bisoprolol does not convert it. Verapamil, no. Verapamil causes rate control in AF, and in SVT, yes, it can block one of the slow fast pathways. And yes, if it is the AV nodal reentry of any time, macro, micro, okay. But obviously in macro reentry, you don't want to give verapamil. So usually it is given for micro reentry or AV nodal reentry, AV NRT type of SVT, which is 90% of the SVT. Okay. That is also a favorite question. Flecainide, yes, IV flecainide used to be a very good choice and we have used a lot. Currently, there isn't much supply, which is not good. But IV flecainide, yes, is class 1, so it can convert. And a parallel question is the pill in the pocket approach. So whoever is having paroxysms of AF, very less often, say once or twice a year, say, you give them 200, 300 milligrams of, say, 4 to 6 tablets of flecainide, make sure they are on a beta blocker, okay? And whenever they go into AF, they take 4 tablets of flecainide, 4 to 6 tablets of flecainide. So oral flecainide also, high dose, can also convert AF to sinus rhythm. And IV flecainide obviously has more effectiveness, but for that you have to come to hospital. So this is the question. A little bit of discussion on, again, AF being such a favorite topic. So this is the AF with a rapid ventricular response. Okay. Fast AF means what is the actual atrial rate, but which is always 350, 400. But yes, you are seeing if somebody is having AF and AV nodal disease, they don't have rapid ventricular response. So if somebody not on beta blocker or verapamil or diltiazem or digoxin develops AF and the heart rate is 60, it means they have AV nodal problem. So that is the question: when flecainide, when amiodarone, when DC cardioversion. Flecainide is when you are absolutely certain this patient has no structural heart disease. Because if they have structural heart disease, there is a risk of ventricular arrhythmia. There was a famous trial on that. So ischemic heart disease or hypertrophic cardiomyopathy, this type of thing, you don't want to give flecainide. So you need an echo before giving flecainide and a proper history. That's why relatively young patients, yes, flecainide, they have less chance of having those. If the echo is clear, less chance of ischemic heart disease. Amiodarone is, you can give anytime. If ischemic heart disease doesn't matter, heart failure doesn't matter, structural heart disease doesn't matter. So it's like a machine gun. So you can give it in any time, but obviously it comes with a price. Sometimes patient can develop acute pulmonary toxicity or more commonly acute hepatic toxicity. So it's a very nasty and a very effective drug. So we have a very love and hate relationship with amiodarone. Okay, when nothing works, amiodarone works, but it can cause a lot of damage if you're not careful. DC cardioversion. When do you DC cardiovert? Another favorite question. Any arrhythmia, golden rule, supraventricular, ventricular, doesn't matter. Doesn't matter if it's a SVT or fast AF or flutter or VT. If the patient is hemodynamically compromised, blood pressure dropping, patient having severe chest pain, and very breathless, developing heart failure, developing basal crepitations, obviously left heart failure, you DC cardiovert the patient. Obviously, you've got to be certain that this AF started within 48 hours. If you're not certain, you need a TOE. If you don't have TOE, do not try to cardiovert. There may be embolus and the patient may have stroke, and we cannot defend that. Okay. So flecainide is the answer. Number 14. Now, number 14 is a 68-year-old gentleman came to cardiology with complaint of chest discomfort, fatigue and shortness of breath for last few months. Symptoms are progressively increasing in nature. On discussion, it was revealed that he's on amlodipine and lisinopril for his hypertension for the last 8 years. Okay. Blood pressure high, 162/98. The pulse is 110, and the pulses alternance was found. That's the favorite topic. You cannot go to exam without knowing electrical alternance, pulses, paradoxes, as sometimes happens in chronic renal failure. But definitely, if you leave a lot of water there, there's a risk of constrictive pericarditis. Pulses alternance happens due to change in stroke volume with a change in preload and afterload. That happens in severe heart failure. Pulses paradoxus is a respiratory dependent change in the pulse intensity or the blood pressure, basically stroke volume. Pulse is the measure of stroke volume. So on inspiration, the stroke volume will decrease because in inspiration, a lot of blood will come to right side, and then it will push the interventricular septum to the left, and from the left will struggle and the stroke volume will fall. This will only happen if there's a lot of water outside the heart so that the free wall of the RV or LV cannot move, and their filling depends on the movement of the interventricular septum. Cocaine, you avoid beta blockade due to unopposed alpha action. Okay, you give nitrate and calcium channel blocker. Nitrate is first. If there is a choice of nicorandil, that will also do. Total anomalous pulmonary venous drainage. So the pulmonary veins rather than left coming to the right. So all the good blood now coming to the right. So how the left side will get blood? So there has to be a hole. So there's a mixing right from the beginning for survival. So there's a neonatal cyanosis. Okay. Genetic syndromes, usually 4 is good enough to remember. Trisomy, known for atrioventricular septal defect. It means low AST, mitral valve defect, high VSD. Turner syndrome, known for coarctation of aorta. Williams supravalvular aortic stenosis, and Noonan syndrome is typically pulmonary stenosis and peripheral pulmonary artery stenosis, okay, or branch pulmonary artery stenosis. Okay, guys. Okay, unless there's any further question, I'd like to finish here.